39 years old female, and you are a doctor in the outpatient. The main complaint, episodic hypoglycemia and abdominal pain. The referral text, I would be grateful if you see this patient with a history of 25 years, type 1 diabetes. Her blood sugar has never been controlled. Her last A1C 10.7, and her main complaint is recurrent hypoglycemia and a change in her bowel habits. Her albumin creatinine ratio 10.2, and the normal is 3.5. The hemoglobin is 10.5, normal from 12 to 15. Vital data, temperature normal 37.1, blood pressures little bit high 160 over 100, pulse 78 per minute, saturation 97. The task, elicit history, physical exam, and construct the differential diagnosis and the management plan. We have today Dr. Walid. Are you ready? Dr. Walid? I don't know he is joining or no. Dr. Walid with us? Okay, if anyone from the other colleague, he wanted to take the scenario, it's okay. Somebody wanted to take the scenario?
Can I please take the scenario?
Sorry, Dr. Walid. Dr. Walid, no, just, no, he sent a message, he is making mute. I don't know why he is making mute. Why he is making mute? Still other colleague joining. Okay, Doctor, sorry for the name, Muzahir. He is raising, yes, okay, I think he is new. Can Doctor, yes, you can start, Dr. Moza, just define yourself, please.
Musaharul Islam.
Yes, yes, Dr. Moza, yes. You can start if you are ready.
Sir, could you say there again the scenario?
You don't have the scenario in front of you?
No, I cannot see.
In the Telegram, just I think it is in front of you. You are in the Telegram group?
Telegram group, yeah, I am.
In Telegram group, I think you have the scenario. I sent it for all of the group. Because you will take time. Sorry, you
Okay,
can make us. Do you have it, the scenario in front of you?
Sir, 1 minute, please.
Sorry, if you are not ready, we can take another doctor.
So, sir, I am ready, sir. That's why I
Okay.
need 1 minute.
Okay, no problem. Okay.
This is Amani, 39 years.
Please, anyone share the scenario in the WhatsApp group of Dr. Imad?
In WhatsApp group, you want to share the scenario?
Yes,
okay.
Doctor.
Okay, sure. I will send it. Okay.
Thank you.
Yes, Dr. Moza, if you are ready, please, we want to start.
Yes, sir. Can I start, sir?
Sure, yes, you can start. Go ahead.
Okay. Hello, I'm Dr. Islam, one of the doctors in the clinic today. You are Mrs. Amani, 39 years old.
Yes, doctor.
Okay. Mrs. Amani, I am here today. Talk to you and as well as examine you. It's okay for you?
Yes, doctor, sure.
Okay. Mrs. Amani, could you tell me what is bothers you?
Doctor, my issues, I am diabetic type 1 more than 25 years ago, and my blood sugars over the last 2 years, it is never controlled. Sometimes I get attacks of hypo, and sometimes it will be more. And my 1C in the last 2 months, it is about 10.5. Although I am taking Lantus and Novorapid, many injections per day, but still my blood sugar is not controlled.
Okay. I am so sorry for your condition, and I will try to sort out it, and as well as I will try solve your problems. It's okay for you?
Sure, doctor.
Okay. And could you tell me how did you start? It is suddenly or gradually?
Which one? You mean the hypo attack?
Yeah.
In the beginning, doctors, I feel lightheadedness and I feel I'm sweaty. And then I have, when I check my blood sugars, it coming 2.5. And sometimes I take some sweet. And in some of the occasions, also my husband, when he awake me in the sleep in the morning, I have difficulty to awake me in the sleep. And he check my blood sugars. At that time, I'm totally unaware of that. This is bothering me over the last 2 year, doctors, more than 4 or 5 attacks of hypo. And sometimes also my husband, he's giving me glucagon.
Yeah. I'm sorry about this. And in every times, do you have any warning sign like any sweating and any awareness of chest beat, or without any warning you have the low blood sugar?
In the beginning, doctors, in the beginning year, I have some warning like sweaty or I feel I'm dizzy. But nowadays, in the last 2 attacks, sudden of all, I collapse. I don't feel any issue.
Okay. I'm so sorry for getting the condition. Okay. You are a type 1 diabetes. Are you compliant on your medication?
Yes, doctors, I'm taking Lantus twice a day, 20 units in the morning and the 25 units in the evening. And before the meal time, I'm taking also Novo Rapid according to my blood sugar, between 10 to 15 units of Act Rapid.
Okay. And okay. And apart from that, do I have any problem in your eye?
Yes, doctors. I feel some blurred visions, and because of that, my sugar doctor referred me to the eye doctors. He examined me and he said I has some issues in my eye, and mostly I need a laser photocoagulation. But he said this is will give it for you after 1 month until I adjust my blood sugar.
Okay. And do you have any history of any weakness, any part of your body?
It is general weak, and I feel I'm tired, not like before.
Okay. And any pins and needle sensation in your hand and feet?
Sometimes it's happened, doctor.
Okay. And anytime history of any loss of consciousness?
Loss of consciousness, as I'm telling, in the last 2 attacks, I don't feel exactly. I'm sudden of all, I'm collapsing, and the surrounding find my blood sugar is dropping up to 2 or 1 sometimes.
Okay. And any history of chest pain?
No chest pain. I have a little tummy pain sometimes, doctors.
Okay. And any history of any heart condition?
Heart problem? No, I don't have heart problem.
Okay. Any early fullness after taking some food?
No, I feel some bloating after I take the food. That's why I am taking just a few meals. I don't feel I'm happy, and I feel just a bloating in my tummy.
Okay. Any abnormal sweating?
Abnormal sweating. Just it was happening in the beginning when I have the attacks of hypo, but nowadays I don't feel sweaty.
Okay. And and what is your waterworks?
Water work is fine.
Any amount, color, frothiness?
No, it is fine.
Okay. And what is your bowel works?
Bowel I have some loose motion from 5 to 6 times, and sometimes awake me from the sleep, and it is watery. This is over the last 2 months.
Okay, okay. And is the loose motion does it difficult to flush?
No, it I can flush easily.
Okay. And do you have any blood or any slime?
No, no mucus or blood.
Okay. Any allergy to any food like bread, pasta?
No, doctor.
Okay. And hmm, do you have any pigmentation in your body?
Pigmentation, I'm not observed something like that.
Okay. And hmm, do you feel, apart from do you feel dizzy when you stand up from sitting position?
Sometimes I am feel I'm dizzy, but not from standing, from sitting position.
Okay. And anybody says you are paler than before?
I think so, doctors. My GP, he said to me, I look pale.
Okay. And do you have any weather preference?
No weather preference.
Any rash in your body?
No, doctor.
Any joint pain?
Joint pain, no.
Okay. Okay. And yeah. Okay. And apart from your diabetic medication, do you take another medication?
Yes, doctors, I'm taking medicine for blood pressures, is known as Rampril, 10 milligram once daily. And I'm taking also because my lipid is high, simvastatin 40 milligram at night.
Okay. Okay. Are you compliant on your medication?
Yes, doctor.
Any recent change medication?
Just only the Novorapid, because of the attacks of hypo, my sugar doctor decreased the Novorapid I was taking before, 20 years before the meal. He kept it from 10 to 15.
Okay. Okay. And what is your diet? Do you take any diabetic diets?
No, I'm taking the usual diets long time ago, doctors. I do my best to avoid the carb, and I'm taking some fruits and vegetables and proteins.
Okay. And do you take, and what is your uh, any do you take any advice of your physical trainer? That means your daily activities.
No, my daily activities, doctors, I'm working as a part-timer accountant. Just only I was enjoying to walk at least half an hour daily. Nowadays, I not walk much because I am afraid to have this attacks of hypo during walking.
Okay. Okay. I want to ask some personal question. Do you smoke?
No, doctor.
Do you drink alcohol?
No, doctor.
Okay. I want to ask a more personal question.
Sure.
Okay. Okay. And do you have any partner?
I am married, doctors, and I have one child.
Okay. Do you have any problem in your intimate relationship?
In the last year, it is not active like before.
Okay. And mm, do you take any recreational medication?
No, doctor.
Do you drink? Okay. And do you drive?
Yes, I'm driving, but in the last 2 months, because of the attack of hypo, the doctor advised me to give up driving. I'm not driving now.
Okay. Okay. I want to examine you.
Okay, doctor, go ahead and tell me which part you wanted to examine, and I will tell you the sign whether positive or negative.
Okay. I first of all I want to examine. I want to know the vitals of the patient.
Vital, as mentioned to you, pulse is normal, blood pressure little bit high, it is 160/100, and saturation normal, temperature normal.
Okay, and I want to see the any postural drop present or not.
Postural drop, no postural drop, both standing and sitting, both are the same.
Okay, and I want to examine the eye for visual acuity, visual
Do you want
field.
to, yes, you wanted to examine visual acuity, a little bit diminished, and patient just she can see, and visual field, it is normal. And if you wanted to examine the fundus, okay, there is a time to examine the fundus, but according to the patient already, she has a retinopathy. You can say it is not progressive. There is some exudates and some no laser therapy. So there is diabetic retinopathy. You can say it is grade 2.
Okay, good. And also I want to examine the patient any soreness in the mouth.
No mouth ulcer.
No, no mouth also. Okay, and I want to examine any paleness in the eye, any anemia.
She is pale.
Okay, and on inside mouth no soreness, and then I want to check the carotid.
Carotid for Perui, no carotid Perui.
And then I want to examine the cardiovascular system.
For what mainly? You are looking for what in cardiovascular?
For in any atrial fibrillation that or any murmur present or not,
There is
or
no
in
pulse
heart.
is regular, as I'm telling, and it is bilaterally equal in the volume and no special character. And regarding the rate, it's normal. And for the heart
And
auscultation, S1 and S2, both are normal. Just only you can hear a little hemic murmur, soft systolic murmur.
soft systolic murmur.
Yeah.
Okay. In systolic murmur, in which area?
All over the pericardium.
Okay. Is this radiated to neck?
Not radiated to the axilla, not radiated to the neck, just all over the pericardium.
Okay, okay. I want to examine the leg. There is any leg swelling present or not? Any edema?
No leg swelling, no pedal edema.
Okay, no pedal. And I want to examine the abdomen. Any visceralomegaly?
No organomegaly.
No organomegaly. And I want to examine the plantar for long track sign.
You wanted to examine, sorry, again?
So plantar. It is
Plant for reflex, plantar
plant.
reflex.
Yes, sir. Yes, sir.
Yes, it's normal.
And I want to examine the pain and touch sensation and dorsal column sign.
She has glove and stocking anesthesia.
Okay, okay. And I want to also the bedside dipstick urine test.
Okay, it's not allowed.
Okay. So, uh, so, what is your concern?
My concern, doctors, I don't know why I have this attacks of hypo, and shall I decrease more my insulin dose, or I will keep the same dose?
Okay. Okay, I appreciate your concern. Before then, I want to ask another question. Uh, uh, Recently, after reducing your dose, you have a experience of hypo?
Still, doctors, after decreasing the dose, still my hypo is coming.
Coming, and anytime is your sometimes all times you have a hypo, or sometimes it is high and sometimes it's a low.
Sometimes, doctors, it is hypo coming sudden of all. Although I'm taking my regular dose, I'm not. I'm taking the diet, and sometimes just after I eat, my blood sugar is shooting. Sometimes reach up to 30 and 32 millimole.
Okay, okay. I'm sorry for your condition. And then I ask another personal question. What is your period?
My period is regular, doctors. Yes, I went to woman doctor. She advised me to take contraceptive pills. I'm using the pills, and my period is regular.
Okay, and any history of any time any miscarriage?
Miscarriage? No.
No, no. Okay, 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 okay. Miss Sani, to confirm your diagnosis, we need to some blood test and some special test. Then I will be able the exact cause. I think at this moment, you have a low hypo. It is related to your long-standing diabetes. Due to long-standing diabetes, you have a lot of complications. You have eye problems. You have after taking some fullness in medical terms. Don't bother this name. It is called the autonomic neuropathy.
Okay, doctor.
And so what we are going to do, we are going to do some blood test and do multidisciplinary team, including eye doctor, kidney doctor, and also a heart doctor and a gut doctor and gland doctor and occupational therapist, physiotherapist. They will give you a proper treatment and management. Are you getting me?
Yes, I'm getting you, doctors.
And
Thanks a lot.
okay, and we also want to explore another gland problem you have present or not. If we find out the exact cause, we will treat you accordingly. Are you getting me?
Yes, I'm getting you, doctor. Thanks a lot. Do you want to take other issues from history or in exam? Suppose if
Sorry.
you have enough time. If still you have enough time, do you want to add issues in the history or you want to examine other part in the body?
Uh, yeah, yeah. I want to
So,
examine in hand. There is
no,
any in
apart
palm or
from just only glove and stocking, nothing abnormal in the hand.
okay, 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 okay. And any history of operation?
No operation.
No operation. And any history of bumping into any object?
Any history of what?
Any bumping any object? Any history of headache?
No, doctor. No, no.
Okay.
Okay. Suppose now time is out and finished, and you said when you answer the concern, the patient most likely she has long-standing diabetes from with complication of autonomic neuropathy,
Yeah.
and you said she might have gland problem. Which gland problem this patient she might has?
Okay, who is grand problem? Well, I am thinking as patient is after load using a decreasing of insulin, she has a history of hypo. So I am thinking there I want to explore any Addison disease present or not. If patient has a Addison disease due to history of hypo.
Okay, so you wanted to rule out Addison disease or adrenal insufficiency. She might associated with her type of diabetes, and you are totally right. That's fine. Any other differential diagnosis in your mind apart from autonomic neuropathy and Addison disease?
And I want to also explore uh, any hypopituitarism and
Hypopituitarism?
uh,
Why you think about
any
hypopituitarism?
uh, sometimes panhypopituitarism also causes the
Do,
sugar
do,
passing.
do you have, she is a patient, she have any symptoms of panhypopituitarism? or
not find.
clinically she has any signs of panhypopituitarism?
No. But
Okay,
sometimes the CKD also causes the hypopituitary low blood sugar due to if patient
okay,
is a CKD, and also I want to see the technique side of the insulin.
that's fine. The patient clinically she looks pale, and it is mentioned to you her hemoglobin is low. What is the cause
Yeah,
of anemia in this patient? Why she has
pernicious.
pallor?
It could be pernicious anemia also.
It could be
Sometimes
pernicious anemia associated with the patient. Okay, what else it could be making
could
anemia
be
in this patient?
could be in this diabetes, type 1 diabetes. There are sometimes pernicious anemia and also Edison. Sometimes Edison also there is a low
Okay,
glucose level.
your first possibility is autonomic neuropathy. How you confirm the patient she has autonomic neuropathy is a workup. What workup you will do to prove autonomic neuropathy?
Autonomic neuropathy. I will do mm, the I will measuring the BP standing and lying and tiltable test and some urodynamics test and gastric emptying study and
Okay,
also
gastric empty study. Okay, this is fine. Do you know how you make this gastric empty study?
mm,
Okay,
gastric motility will be low dysmotility.
the patient gives you a history of little bit tummy pain and floating and loose motion. What is the cause of
Yeah,
that?
that is a diabetic gastropathy.
Diabetic gastropathy or gastric empty syndrome, or you can say gastroparesis as a cause. Any other cause you want to rule out?
Uh, I want to rule out any malabsorption syndrome
Malabsorption
and
syndrome due to what?
uh, m- malabsorption syndrome due to diabetes. Long-standing diabetes also causes the
Okay,
malabsorption.
that's fine. I think Dr. Musa for the timing. Yes, and I will come for my comment, and then I will listen from the colleague comment. Thanks a lot for you for the history. You did the history. I can see very well. Although some parts you miss, which may be not related, but it is important to be mentioned. Of course, it is important to mention. And for all my colleagues, please in the history taking, do your best to cover all the items of the history, whether related to the scenario or not related. Because in the real exam, you don't know it is related or not. Like in this patient, he forget to ask about travel history. Okay, if he asking
Yeah.
me what's the travel history, the last 2 years I was in Spain, I spent for 1 week ago. Of course, it is not related to the history, but better from the history wise to ask. Yes, better to ask. This one point. He forget to ask about the family history. What about the father and the mother? If in is any other familial disease, might the father or mother also both diabetic? The family history also, it is very important to be mentioned as a part of the history. That's do your best to mention all of the items of the history, and in the exam, when you do a lot of mock and you make active with your colleagues, if you are using to miss the sum of the items, you can remember yourself and write in the plain paper, I missed the family history, I missed the ministerial history, something like that, just to remind yourself about these items. This is one point. The scenario as in front of you, patient, she is long-standing diabetes type 1, and she is presented with recurrent attacks of hypoglycemia. In the beginning, it was the awareness with the hypoglycemia. She feeling sweaty, she feeling a headache, palpitation, whatever the symptoms of hypoglycemia. She is aware, but later on in the last 2 or 3 attacks, she doesn't aware, which is known as hypoglycemic unawareness. Once any long-standing diabetic patients goes into hypoglycemic unawareness, the most important cause to be ruled out as a complication of diabetes is autonomic neuropathy. As the doctor Musa said that this is the first possibility to be ruled out in this patient, and he is totally right. Diabetic autonomic neuropathy. In all patients with long-standing, especially they have hypo and hyper, up and down, and the A1C is not controlled, a diabetic autonomic neuropathy must be ruled out in this patient. How to rule out? We have a lot of tests. In reality, most of these tests, just we can do it. One of the tests, which is known as head-up tilt test. Head-up tilt test, the patient is lying flat on the bed, and just we raise the head in at different angles, started from 30 degree until we reach to 90 degree. In every raising 30 degree, from 30 to 60, from 60 to 90, we measure the blood pressure and the pulse and the oximeter. We found a difference in low side. It means this is a positive head-up tilt test. And this signifies the patient, she might have diabetic autonomic neuropathy. If the patient gives history, as in this patient, she has tummy pain and floating or repeated vomiting or repeated loose motions, and I'm thinking about what's called gastric paresis or gastric empty syndrome, we can do what's called gastric empty test. Gastric empty test, how you do it? If the examiner asking me how you do this test, I will give the patient light meal with radioactive material. And the diagnosis of gastroparesis, if more than 10% of the meal remaining in the stomach after 4 hours, this gives me the diagnosis of gastric empty syndrome or gastroparesis. And this is the cause of tummy pain or loss of motion. But a very important point in this scenario, patient, she looks pale. And the most likely cause, it could be anemia of chronicity, chronic long-standing diabetes, or other chronic disease the patient she had, she is dyslipidemic, and also the patient, she is hypertensive. Once is mentioned she is hypertensive, for how long? He asked about if there is any new change in the medication, but I should know for how long she is hypertensive, for how long she is dyslipidemic, because the patient now has multi-risk factors. If the patient looks obese, he asked about smoking and alcohol, and what about the lifestyle, all of these issues, if I have time, better to ask about this in the history. The most important point, keep it in your mind, if you have a scenario of diabetes in the exam, usually the patient, it will be long history or means chronic history, is not something acute. So once I have a chronic history like this, and you have enough time, as I'm telling you before, for the history, the timing to adjust from 10 to 11 minutes maximum, and the remaining 3 to 4 minutes for the clinical exam. And then the last minute, I can answer the patient concern. This is a 15 minutes. How to adjust the timing in the exam, which is a very, very important. So once the patient is known to be diabetic with a type 1 or type 2, and she is long-standing, ask about the duration of diabetes, compliance, as the doctor said, type of medication, any change of medication, the diet, and she is follow the dietitians or no, the daily exercise and the activity, because if the patient do more exercise, and this is maybe the cause of hypo, If the patient taking extra dose of insulin and she is not eating, maybe this is a cause of hypo. And then don't forget to ask all of the complication of diabetes, whether micro or macro complication. If the patient she has any attacks, previous attack of stroke or TIA, or if the patient she has any previous attack of ischemia or MI. About the vision problem, of course she has a vision problem and diminished in vision. That's why the doctor, he did, and I should examine the eye, started from the acuity and the visual field and the fundus at the end. Mostly in this specific case, the fundus, it will be dilated, and you should pick up what is the clinical finding in the fundus. So be aware from this if you have the similar patient in the exam. Don't forget to examine the fundus, and most likely in the exam, the fundus will be dilated in this specific scenario. And I can found some abnormality, and I should mention what this abnormalities. It is grade 1 or 2 retinopathy in front of me. The doctor said, ask about if she has nephropathy. He asked about the amount of urine or if there is frozen urine. Also, he asked for the personal relationship or the intimate relationship, especially if a male and the patient has impotence, or female and she has loss of libido because of diabetes. I should mention very important about the numbs and the tingling if the patient develop peripheral neuropathy. And also I should examine the patient clinically for peripheral neuropathy, just only by cotton or pinprick. Like in this patient, she has peripheral neuropathy in form of glove and stocking anesthesia. Very important point. Once I'm thinking the patient, she has diabetic or hypoglycemic unawareness. What came in my mind about the causes of hypoglycemic unawareness in a diabetic patient? It is very, very important to know what is the cause of hypoglycemic unawareness. First, long-standing diabetes, patient more than 15 years. Most of the diabetic patient, long-standing, she has diabetic unawareness or hypoglycemic unawareness because of the duration of diabetes. Especially this duration, the patient, he or she uncontrolled. A1C always above 10. This is one. Very important and a tricky point in this specific scenario, and I prefer myself to ask specifically, because sometimes the patient, he not inform you or gives you the information unless you ask this specific information. So be aware of that, because it is written to the patient, some information he will never mention to you unless you ask specifically about this information. Like in this scenario, if I'm aware, one of the cause of hypoglycemic unawareness, which medication, like if the patient taking beta blocker. Patient is known to be hypertensive. He said, I'm taking Rimapril. I'm asking in this specific scenario, if you are taking a medicine which is known as, you can mention, like patient is taking Concord, patient is taking tenormin, any types of beta blocker. Because of course, if the patient long-standing diabetes and he is taking one of the beta blocker, one of the cause of diabetic hypoglycemic unawareness, or the beta blocker masks the hypoglycemic symptoms. When also if the patient taking excess alcohol, one of the cause of hypoglycemic unawareness, or if the patient has elderly patient above 60 or 65, and he has tight glycemic control. That's why in all elderly patient, better to keep the A1C around 8. Will not drop the A1C below 8. This is for elderly patient when they have a hypoglycemia, keep the sugar in the high level, not to reach for tight glycemic control in an elderly patient. Of course, this lady, she is not elderly, she is 35 years. So again, the causes of hypoglycemic unawareness, the long-standing diabetes, and especially the patient develop autonomic neuropathy, patient taking beta blockers, patients taking excess alcohol, patients have tight glycemic control in elderly patient with long-standing diabetes. The third point, which is very important with all diabetic patient type 1 or type 2, when the patient develop anemia, keep in your mind they might associate it with pernicious anemia, especially if mentioned to me in the scenario, hemoglobin is low and the MCV is high, above 100. Patient, she might have pernicious anemia associated. That's why I should ask about the type of food, if the patient is vegetarian, or if the patient taking meat and all of that, because he might develop pernicious anemia. Again, in patient may be associated with other autoimmune disease, as in this scenario. And this is very important point. The doctor also mentioned about the Addison disease, because Addison disease, if associated with type 1 diabetes as a part of autoimmune disease, patient, she might develop hypoglycemic attack. So Addison disease in this specific patient must be ruled out. A very important patient also, he has tummy pain and loose motions. It might from autonomic neuropathy, of course, due to gastroparesis, but still, celiac disease also here to be ruled out. So the differential diagnosis in this patient, number 1, autonomic neuropathy. Number 2, I can keep Addison disease. That's why I'm asking about pigmentation. And of course, clinically, I search for any pigmentation, palmar crest pigmentation, or buccal mucosal pigmentation, or the pigmented scars if the patient has previous operation, to rule out clinically Addison disease, plus also to check the postural drop if the patient has postural drop in the blood pressure. Celiac disease also, I should be ruled out once the patient has tummy pain or she has loss of motions, even though if the patient doesn't have any reaction or allergy to any specific type of food like the berry or pasta and something like that. This is my comment about this scenario, but thanks for the doctor. He did a good job regarding the history and the differential diagnosis and my comment. Again, before I'm coming to your rule, best congratulations for all the candidates and the colleagues both in the previous exam, and wishing the best inshallah, and to congratulate you in the future for the next diet. And some of the colleagues coming in these sessions, they achieve a very highest score. Thank God for that, and best wishes for all of you inshallah.
Dr. Ahmad,
Yes, doctor.
Thank you, sir.
can you give us some notes about how to treat this patient, because she's already having high A1C and now she's developing low attacks of hypo. So how to balance between these issues?
Yes, this is a very good question. How to manage these patients with a hypoglycemic unawareness, and most likely the patient has gastroparesis. These patients, of course, I should adjust the insulin, especially the short-acting or the rapid-acting one, which is the Novorapid, and better in these situations not to give the rapid-acting one. Either give the intermediate or the long-acting one. This is one. So the rapid-acting in patient with autonomic neuropathy or has hypoglycemia, better to avoid the rapid-acting. This is one point. Either the intermediate or the long-acting insulin. Advise the patients to take multiple snacks, not only to take 3 meals, breakfast and lunch and dinner. Just ask the patient to take multiple snacks every 3 to 4 hours. Just if most of the time the patient, he is eating and he has multiple snacks. A very important point also, we can use, even though if the patient type 1 diabetes, in type 1, to use the incretin drug like GLP-1 analog in a type 1, it has a rule? Yes, it has a rule. We can use any type 1, although it is an oral medicine or it given in form of injection. So I can use any drugs like incretin drugs like the GLP-1 analogs or DPP-4 inhibitors. And once we are using these medications, of course, the dose of insulin becoming less. This is one. And ask the patient to avoid, if he is taking beta blocker, to hold. If the patient excess alcohol, again, to hold. If the patient is taking some, what can we see, will give what's called prokinetic drugs, like metoclopramide. Prokinetic for the tummy pain, for the loss of motion, or if the patient has repeated vomiting and something like that. So how to manage the hypoglycemic of awareness? One point is to not to give act rapid, to give intermediate or long acting in a short doses. 2, we can start to use the incretin drug like GLP-1 or DPP-4 inhibitor. It has a rule in type 1. Number 3, to ask the patient to take multiple snacks, not just only to take a long time between every meal, and to give the patient prokinetic like metoclopramide for the diarrhea or for vomiting. This is the management for the patient. Very good question. Yes, any further comment?
Doctor, we can put this diabetic nephropathy as a cause of insulin, because
no, not nephropathy. Diabetic not nephropathy. This is an diabetic, what we said, peripheral neuropathy, or better the word here to be autonomic neuropathy, not even peripheral neuropathy.
We can put as a cause because there is albumin creatinine ratio high.
No, the albumin creatinine ratio, it is mentioned here to the patient, means the patient has all the micro complication. He has retinopathy because he has eye problem. He has nephropathy because he has renal problem. That means the patient, he develops a micro complication. And of course, all long-standing patients, they have micro complication. That's why in the history, I should ask about the macro one, which if the patient developed TIA or stroke or MI and so on like that.
If the patient already have nephropathy.
Nephropathy, yes.
Yeah, this will decrease the insulin clearance by...
yes, of course. If the patient has a degree of renal impairment, the insulin dose must be decreased.
Yeah.
Okay, insulin dose must be decreased in patient with nephropathy, diabetic nephropathy, or elderly patient. The dose it should be adjusted very well.
Like that. Yeah.
That's why in nephropathy and the elderly patient, keep the A1C around 7.58, not below 7. Not like in adult, not like in healthy one. The A1C will not have tight glycemic control in nephropathy or in elderly patient, because elderly patient already they have some renal impairment, and the diabetic long-standing they have renal impairment. That's why the insulin dose must be adjusted.
We can put as a differential here?
Not a differential. Diabetic nephropathy, not a cause of hypoglycemia. Okay, you should mention autonomic neuropathy, because the autonomic neuropathy, yes, this is the cause of hypoglycemic unawareness. We cannot say diabetic nephropathy leading to hypoglycemic unawareness, nothing like that. You get my point. You should mention autonomic neuropathy.
Okay.
Yes. Any further comment, my dear?
Yes, doctor, please.
Yes, Dr. Eva, okay.
Are we putting the Addison in differential while the patient is, her blood pressure is 160/100?
Yes, of course. Yes, of course. The patient, he is hypertensive and he is taking medication. That's why blood pressure is not controlled. We need to adjust his blood pressure for the control. Ramipril, maybe we increase the dose or we can add other. This is another point in the management of the patient. But hypertension per se or high blood pressure reading doesn't rule out Addison disease. Addison disease in any diabetic patient, especially type 1, it should be both as a differential diagnosis especially if the patient develop hypoglycemia, patient develop any attacks of postural drop, patient he has difficulty to stand from sitting positions, patient has weight loss, insignificant weight loss, unintentional. Of course, Addison disease must be ruled out.
Okay, thank you.
Okay. Any further comment, my dear?
Dr. Ahmad,
Yes, doctor.
can you repeat how to diagnose autonomic neuropathy? You said to put the patient at
yes, we have two
33
methods. One method which is known as head up tilt test. Head up tilt test. Patient is lying flat on the bed, and just we raise the head from 30 degree to 60 degree, and then from 60 to 90 degree. And when it changes the degree of the head, just will measure blood pressure, pulse, and pulse oximetry to be measured. Once there is drop in the reading, this gives you the patient as if postural drop or the head tilt, we said positive. This is a sign of autonomic neuropathy.
What
Another
is about
sign,
the pulse also will be drop?
yes, pulse also it will be drop. And the oxygen saturation also it will be drop. Once we raise the head from the degree to degree, it will becoming down. The
How much
other
will
one,
drop the pulse and BB?
yes, about the blood pressures, yes, from 15 millimeter mercury, pulse just about 10 beats as a drop. Saturation may be from 3 to 5% for the saturation or oxygen saturation.
Okay.
Gastroparesis or gastro-empty test, you will give a light meal with radioactive material, and after 4 hours, just check. This is the if more than 10% of the meal is still persistent in the stomach, we can make it. This is a sign of gastroparesis or a positive gastro-empty test. Another test also, but mostly it is not done, or it needs. If you know and read about for the gastric empty test, which is known as wireless motility capsule. Wireless motility capsule, it is done by the gastroenterology. The patient is swallow one capsule. This capsule, it is connected to a small electric device. This electric device is a very smart one, and it can measure the motility of the GIT once the capsule passes from the esophagus down to the colon. It will measure the motility. That's, of course, the motility here is becoming very less, and you can measure this by a capsule. It's known as wireless motility capsule. But it's little bit this something advanced. Usually it will not asking you in the exam. Any other comment, please? Okay.
What is the idea?
Sorry, because somebody, please, can you mute some? One doctor, please, can you mute yourself? Okay. Sorry, go ahead, doctor, please. Sorry, you have a net issue. Sound is very interrupted. I cannot listen. Hello?
I ask what is the idea? Okay.
Yes, I'm
okay,
with
doctor.
you.
What is the idea of using GL glycogen like protein or factor peptide in type 1 diabetes? What is the idea?
Yes, I will give it to you in short. What is the actions of the GLP-1 agonist? The incretin effect. What means by incretin effect? Incretin effect when the patient he is taking the oral food, when he is taking the food. Okay, once he is taking any oral food, there is a hyperglycemia level. The hyperglycemia level, just this is what's called the incretin effect. How to minimize this incretin effect? Means the hyperglycemia after taking the food. This is the actions of the GLP-1. GLP-1, yes, when it acts, it will delay the gastric, okay, making empty. You give you a feeling of satiety, and it will increase more the insulin secretion, of course, in type 2. You know, in type 1, there is no insulin. We know all of this information. But the action here, it will act through the brain one, will give you the satiety level not to eat more. and it will give you the full stomach. This is the more action. That's why your meal is becoming less, and it will help to reduce the insulin dose. That's why the patient will not go into hypoattacks or to decrease the frequency of the hypoattacks. This is a mode of action in type 1. Of course, in type 2, it has a very good rule in type 2. But in type 1, you can prescribe. Of course, you can prescribe. Okay. Plus, also, it has an advantage rule in type 1 in reduction of the weight. If the type 1 patient, diabetic patient, they have gaining weight, or they have a metabolic syndrome, or they have insulin resistance, or they have, metabolic syndrome, it helps a lot to losing weight. It has a rule. Of course, it has a rule. If you know the information, you can mention in exam. If you don't know, there is no any problem to mention. But if you know, of course, you mention to the exam.
Okay. So doctor, can I ask one question?
Sure.
Because the patient is also having gastroparesis, and we are giving GLP-1, which will also further reduce gastric emptying, will not increase bloating and...
A good point. Yes, already the patient has gastroparesis, and we are giving a GLP-1. It will increase the gastroparesis, or it will complicate the issues. It's not like that, of course. That's why I'm telling you to give probiotics like metoclopramide. So it is a combined issue, but the most important one in this specific patient, to avoid the rapid acting insulin, and to give the patient short snacks in between, just every 3 to 4 hours, to give short snacks, not to eat more, because to shoot the blood sugar again, and also not to keeping a long time of fasting, and he is taking a rapid acting insulin plus the short acting or rapid acting insulin. So how to adjust between both? Of course, it will need from the patient and from you to minimize the insulin dose and to avoid the rapid acting. Plus, if you go just on the GLP-1 or DPP-4 inhibitor, short amount is not the higher dose, plus the prokinetics. It will help, of course, for the patient. Of course, it will help.
Thank you, sir.
Sir, can I ask a question?
Yes, doctor, go ahead.
Sir, in this patient, there is some globin stocking distribution of peripheral neuropathy. So should we treat this?
Of course, peripheral neuropathy, because he has globin stocking, of course, we should give the issues for the peripheral neuropathy. Whether you can give some of the antidepressant, gabapentin, or to treat the patient with P complex and all of this. If patient proved to have a pernicious anemia, of course, you should treat the peripheral neuropathy.
Okay, thank
you. I think the timing now. Thank you for all of you for this good discussion. Wishing, inshallah, in the next week, mostly it will be next Tuesday, we'll have a communication scenario, and best wishes for all of you, and see you next week, inshallah. Thank you.
Thank you, sir.